record on. There you go.
Hello, hello, hello. This is Truth Be Told. This is Dr. Walter Aka.
And my name is Leroy Horton.
You are my special guest again. We told you round 2 was coming up. We're very excited. I'm actually very excited about this. As you can see, Dr. Kyle Dumper is not with us. He was apparently on vacation or something.
No, he's out there doing some Navy SEAL type stuff. It looks like he's at some retreat with some performance group.
Okay.
And they're doing like underwater weighted dives and breathing exercises. Like he's gonna come back a changed man from whatever.
It's funny. I didn't even know about it. Right?
Yeah,
You're the one that was like, you told me, and I'm like, man, I need to get back on social media, or I need to talk to him about our friendship. Yeah.
So what's up with the social media hiatus? Why don't you tell us about that?
Right. Yeah. So for me, social media is just like, it's a place to just connect with people, right? But it got really toxic. Like I want to say 6 months ago, right? With the whole election and all this other stuff. So I was like, for me, I like to just separate myself from anything toxic. I really do. And it just got to that point where it just became too much. You know what I mean? Like I was starting to see people in different lights, and I was like, that's just not me. That's just not who I am. You know what I mean? I'm never going to let anything dictate how I feel about something. Right. And so then I said, you know what, let me just get off of here for a little bit. And it's actually been awesome because it's allowed me to do a lot more. And it's allowed me, you get to the point where every time you do something, you take a picture of it. Or you have to share it. You have to do this. And so we went to dinner for my wife's birthday on Friday.
Oh,
no one had their camera out taking pictures from this angle. And it was literally just us hanging out, having a good time. You know what I mean? So that's why I said, okay, you know what? I think the social media aspect for me is just going to be reduced, So I might get on there once in a blue moon. It's still on my computer, just not on my phone.
Right.
You know what I mean? And I'm not telling anybody to do it because I know social media is like a drug. You got to wean off. You know what I mean? I don't want anybody to have a hangover or go insane or depressed. But to me, I think having that reduction really does clear your mind to do other things and to grow. And I know with you, with you starting residency and stuff like that, I bet you that the fact that you're not even able to do what you used to do with social media has allowed you to do other things and focus on other things,
It definitely has. It becomes one thing that I've tried to do is I've tried to just I have a personal page and a professional page. Right. And the only things I really follow on my professional page are like either colleagues or organizations. And so every now and then I'll think to post, just because, especially since we put on courses, it's nice to stay a little active, right, top of mind. But I don't always go to my personal page unless I'm just going there real quick to post something about the kids, and then I get off, and I don't do a lot of scrolling or paying attention. So taking a hiatus from social media, I think, has a great value every now and then, because you really don't realize the subconscious effect it can have on you,
That's it. And that's exactly, and what changed my mind a lot was I watched a Netflix documentary, what is it, Social Network or something like that.
Yeah.
A Social Dilemma or Social Dilemma, I think is what it's called. And I was like, man, they're not kidding, because you find yourself grabbing for your phone even when nothing's happening. Right. you want to see what's going on out there, and after a while I just was like, this is too much. I like my sanity. Right. So again, it is like I said, I understand from a professional aspect. I do believe social media, Facebook, Instagram, Twitter, they're very powerful ways of communicating, ways of getting your name out there. If you're a doctor and you have a practice, you need to be on social media. You could also hire somebody to run your social media network. Right. You see what I mean? Without you having to be 100% active in it, So I would highly recommend that. Maybe we can do another episode on that. But I also think that taking that hiatus and just being like, you know what, let me get off of here just to clear my mind is invaluable.
Absolutely. But tell me about these worlds, man. You said the worlds were going on today, and I'm not really abreast to many sports. So what worlds were going on today?
Well, so there's a lot. So today we had Wimbledon, right? We had Euro 2021. So it was Italy versus England, and that's for me. That was what I was watching.
Okay.
That was what was, you know. So for me, I remember like we set up the appointment, and I was like, oh god damn it, like I forgot that. You know, that runs into Euro 2021. So I was like, hey man, can we move it to another time? You know, so I don't mind. It's just like right now, it's like so many things happening all at once, sports related. You know, I know the NBA finals is happening right now. You know, I'm okay with missing that. But you know, I'm a soccer guy, so Euro. And last night was UFC. My brother was watching that with me, and then also what was it? Oh, Argentina versus Brazil.
Okay.
For the for the Copa Cup finals.
Right.
So Argentina ended up winning. If I, you know, don't watch this and be spoiled. Spoiler alert. Yeah, spoiler alert. 4 days later, Argentina won. You know what I mean? So that was, you know, it's been a busy weekend, but it's been fun, man. It's been actually a really chill weekend. We've gotten a chance to just take it easy, relax. My brothers came down here just to visit for like 4 days. You know what I mean? So it was kind of nice to have them here this weekend, but it's good to have them also leave so that I can actually just relax too. You know, because they like to stay up late, and I'm an old man, so like, you know what I mean, when they're up at 11, I'm like, God, man, aren't you tired yet? You know,
looking at your watch like,
right? Woo, it's getting late there, buddy. You know. But anyway, man, we are here. Everybody wants to see the new presentation again. Okay. Just like last time, I have no idea. I haven't seen this presentation at all. So I'm really looking forward to it. And we got some great feedback from your presentation.
Oh,
like it was, good. Yeah, no, people really enjoyed it. And including myself, I really was like, man, this is some top level stuff here. And I hope people really are seeing that and going, man, this is what, if this is just the top, I could only imagine what your courses look like. Right. If you're showing us this, right, I could only imagine like how deep you get into everything. So yeah, this is incredible. I'm excited. Let's get it done. You know what I mean? Let's get going.
Yes, sir. Well, let me set up the screen share here.
All right. And then, for anybody who is just like the last one, and I'll keep talking. I'll tell everybody, just like the last one, you got to go on YouTube. You have to go on YouTube. Truth Be Told podcast. Truth Be Told podcast. Search that. Get on there and watch this, because this is the only way you're going to be able to do it. Let me completely tell you, listening to it on the podcast, I don't care what platform you're using, is not beneficial. You have to see the pictures. You have to see what he's explaining. Okay, so we're about to begin. So I'm going to be quiet and let the master work.
All right. Well, I appreciate the kind words. So last time we did some anterior grafting in preparation for implant placement. This one, I was a little torn whether to do another anterior case. I think I wanted to focus more on some larger scale bone grafting. So I chose this case where we have a upper right maxilla where we're missing a number of teeth and we got a broken tooth. So number 6 is broken off to the gum line. Obviously, it's no longer restorable. We're missing 5, 4, and 3. Now, it's a little hard to tell off just this picture because it's a little small, but this is our ridge, and you can see where this cross section is. So this is just behind our canine. Our ridge is relatively deficient, going from the area of number 5 going back to just the beginning or towards mid number 3. Deficient to put good size implants, especially on a patient that, you know, if we're looking here, his gingival biotype is medium to thick, but one of the things that stands out, and at this time in my career, I wasn't taking the full, you know, frontal, side, and full series of photos, but you can see some pretty active wear. Okay, so we know that this guy is a Bruxer grinder. We know that technically there is restorative space, but I want to make sure I'm not trying to load him in with a bunch of mini implants to.
Yeah, and I was going to ask you that. Like, what if another argument could be, well, I could put, you know, mini implants here. What's the problem with that?
Right. Well, you know, in my experience, when it comes to mini implants in areas that take a lot of physical load, I haven't really seen them be successful. Now, I can't say that from experience because I've never been one to use mini implants, but I've seen a fair amount of them fail or where they've come into me and they have, multiple mini implants and a molar built on them, and you see a ton of bone loss. So between the literature that I've read, I've read, and the clinical experience of what I've seen, I'm not a big fan of just throwing a whole bunch of mini implants and trying to restore something on them. If we are looking at the dimensions here, we got just under 6 millimeters of bone. If we want, at least 1.5 millimeters of bone on either side, now we're looking at an implant that's got to be like a 2.7, to give us an implant that's in good medullary bone, that's got good bony support on either side, but prosthetically that has its own challenges as far as trying to put a realistic size abutment on a mini implant that's going to have a good emergence profile. And then when you're trying to give it the load of almost an entire quadrant or quite an entire posterior quadrant, I just don't trust that either the prosthetic parts or the amount of bony support given the diameter of those implants will be adequate. But I have met a fair amount of people at conventions that swear by mini implants, and maybe I'm just speaking out of turn in that I haven't tried it and it hasn't worked in my hand, so I can't speak to it. What are your thoughts on mini implants in high activity areas like this?
Right, and I completely agree with you. Mini implants for me is just the same way. I've just never seen too much success with them.
Right.
That's again my personal opinion. It has nothing to do with anything. And then on top of that, I just don't even think I would even think about it because of the fact that the patient has that much wear on the incisal edge, right? And you're going posterior. Posterior is going to take more forces than the anterior aspect. So maybe a mini implant in the number 8 or 9 area, not that bad. Now we're going posterior. Now you're talking about actual true occlusal forces that are just, they're brutal.
Right.
And I just don't think a mini implant would do anybody justice. But there are research that actually, like you said, there are research that show that mini implants have the same, failure rates in the posterior as platforms that are greater than 3.5, 4 millimeters.
Right.
So again, there's research that shows that. But again, I've never seen success or long-term success in that way.
Right.
So maybe, I don't know, maybe they did a lot. They saw the patient every month. Maybe they did the occlusal adjustment every month. I don't know what that research says, and I would have to go back and actually analyze it.
Right. Or maybe they're just completely out of occlusion.
Oh, there you go.
When we put mini implants in the anterior, the first thing we do is make sure that the tooth, there's no contact at all. And in the front, you can get away with that. If you're trying to restore someone's entire posterior that has to function, I just don't think there's any way to realistically, even if you keep the crowns out of occlusion and maximum intercruspation, every time they put a bolus of food back there, they're chomping down. So there's no way you can really avoid a full or a really healthy dose of occlusal forces in the posterior. It's just not that possible, especially with this many teeth that you're trying to replace. So my goal here was trying to vertically. I think I'm very good. We've got probably almost 15 millimeters of vertical bone, but we have to augment horizontally to give us enough width to put in, minimum, 3.7 to 4 millimeter implants. All right, so first thing I like to start with, and I think we talked about this last time, is you got to flap the tissue, and you got to be able to feel comfortable enough flapping tissue to allow you to see what you're doing. Okay, one of the things I see with a lot of people that take my class or people that I try to do one-on-one instruction with is they're very timid when it comes to laying flaps. And what you'll see in this picture, I do a vertical releasing incision in the posterior. In the anterior, I don't. I do include initially, and you'll see here, let me see if I can get my laser pointer. Let's go laser pointer. So initially you'll see I do a circular incision, I maintain this papilla intact, and I'm able to get some stretch of that tissue. but I really don't know exactly how much I can stretch it over just yet. And so you'll see me adjust this in just a few slides. What I determined was that this area right here was okay horizontally, it had enough width. And so really I just needed to augment this particular area in question. So the areas of number 4 and 5. This area here, as you'll see, as you have seen with canines, even though technically the width is pretty good because the canine root is there, this root is almost translucent. It's so thin. And you see that in canines very frequently. That's why I don't do a lot of immediate canine implants, because it's really hard to get such a long root out of there without fracturing, damaging, or sometimes even decimating that razor thin buccal plate. So what I like to do, especially with canines, is see how I can get it out, graft it, come back, and then not have to give myself the headache of the technical difficulty of trying to do an immediate implant and get this long root preserving that razor thin bone. Okay.
You talked about doing a vertical on the distal instead of the anterior. Mm-hmm. And was that for you? Was that just aesthetic purposes only?
Yes and no. If push came to shove and I absolutely needed one in the anterior, and there was no way I can get tissue to stretch over the volume I was adding, I would have to add it. But there is always that concern of creating either scar tissue or clinical attachment loss when you start doing anterior flaps and including vertical releasing incisions, because you are disrupting the blood supply. And in certain cases, you'll see where you have some bone loss, but the tissue is great where it's at, right? And so you might have a deep pocket, there might not be inflammation, but you definitely have 1 millimeter or 2 of bone loss and maybe a 4 millimeter pocket, and because the tissue is still at the CJ. But then if you lay a flap on that and you put it back, there's a really high chance, because that bone loss, especially if there's interdental bone loss, that tissue is going to follow that bone now. Now that you've disrupted the blood supply, you've disrupted the connective tissue attachments that we had to the cementum. And so if I can't avoid that in the anterior, I like to at least attempt to. Every now and then you come to a situation where you're just like, hey, there's no way I can finish this surgery without extending this out, extending the amount of teeth, or just even doing a slight vertical incision just to get a little bit more stretch so it's tension free. But when possible, if I can avoid the potential scar tissuing or recession, then I always do aim for that. Okay. So you see, I did get the tooth out and I was able to preserve that bone, but you'll see that once you get that tooth out, there's often small or large dehiscences. And it is razor thin. It's absolutely razor thin. So what I decided to do was, instead of trying to do any type of decortication on top of this, if I had a really thick ridge, I might even try and bulk that canine ridge up just a little bit, anticipating there might be a little bit of shrinkage during healing. But it was so razor thin, I was not going to puncture it, risk it. I was going to maintain it as much as I could with a socket graft, and put the bulk of my particulate matter that I'm using to augment the width on the areas that I knew were truly deficient to begin with, which was numbers 4 and 5.
Okay. I like the fact that you said that, because, I mean, I always say keep it simple, right? You have a cup. All you're trying to do is fill that cup up. That's what the extraction socket to me looks like. It's just a cup, right? I'd rather, that's easy to do, is fill that up, because you're basically telling the body to basically, hey, take care of the bone that I put in this cup. Right. That's it. So you have cells that are telling the body what to do, or the bone what to do, from the facial, the lingual, the buccal, and the mesial and the distal, right? So basically, it's surrounded. Your bone graft is surrounded by bone, which is going to then entail, hey, this is what you need to do. Right. You go further back, now you basically have 1, maybe 2 walls that are telling the bone graft what to do. So it's a little harder in that area. So
Yeah.
you basically did it. You said, let me just not mess with this and take my win here,
Right.
and focus on the part that it's going to be a little harder.
Exactly. And so at this point, I clean and curette out the socket to get any remnants of any soft tissue, if there was any potential, infectious tissue or abscess, because it was a fractured tooth, even though there was no PA lesion and no symptoms on this tooth. It was a necrotic tooth. So I did get the tooth out. I cleaned the socket out really good, got really good, not only clean walls, but bleeding from those walls. And then I decorticated my bone. Now, interestingly, in all the research that I've written, or that I've read for some of the articles that I've written, there's still some controversy over decortication. Okay. I think recently I was reading one from Tarnow and some others where they did some histology on grafted areas with a control group where they didn't decorticate and an experimental group that they did decorticate. And they found that the results in attained width were similar enough. The amount of new bone formed was slightly different, but not statistically important.
Yeah.
Or significant. But what they did found was there was a statistical significance in the amount of angiogenesis in that new bone. And I think that as the studies continue to pile on, they're really going to look at not just how much bone do you have. And we know that when you do a bone graft, you might get anywhere between 30 to 45 or 50% de novo bone, and the rest is still, remnant bone grafting material. But that's more than enough to house the implant, support the implant, and integrate to the implant, right? I'm interested to see in the long-term studies of the viability of that bone, given that there seems to be, especially at the 7 months to 1 year, there seems to be some significant differences in the amount of blood supply that the bone has when you do decorticate, right? And so, but I was always taught decortication, and given that the literature does say that there is some advantage, some benefit to decortication, and it's extremely easy to do, and it doesn't cause any extra morbidity or, doesn't take a lot of effort on my part, there's no reason not to do it, okay? But you'll see here, I end up, after I decorticate the bone, and I skip the whole PRF, because I think we've talked about that before, and we can refer your listeners to some of your previous episodes where we have our conversations on PRF.
Right.
But my allograft, I use PRF in all my surgeries. My allograft is hydrated with either platelet-rich plasma or the exudate that comes off of the PRF membranes that I make. So we're infusing it with those extra growth factors. But you can see I fill up the socket, and then I just pile on the bone, trying to get as much width as I can. If we started with about 5.8, and let's say I want to put in a 4.1 millimeter implant, and I want at least 1.5 millimeters on either side in an ideal world. So I need to get, at least about 7.5 millimeters of bone from the 5.8 that I had. Now, if I'm going to factor in maybe 10 to 15 to 20% shrinkage from the initial volume that I build up, that may mean I want to add, if I start at just under 6, I want to add at least about 4 millimeters of bone graft material in terms of volume, knowing that as it heals, it's going to shrink a little bit, and it'll shrink no more than down to about 7.5 millimeters from that 9 or 9.5 that I build up, okay? So that's why you'll see a lot of times I'll pack on the bone as much as I can, but then I usually take an instrument and I kind of pack it down, flatten it, shape it. I look at my tissue, see how much I can extend over it. I might measure it with a probe to see if, all right, do I have too much bone? Is this overkill here, or am I over-engineering to a reasonable amount, right? Because I think a lot of us tend to over-engineer, anticipating some of that shrinkage, but you can definitely go crazy with it. And then, that can give you a host of other problems, especially if you have trouble now closing that surgical site and you're, creating a lot of tension on those tissues. compromising blood supply, compromising your ability to stay closed, and potentially exposing the underlying membranes and bone and so forth. But let me go back real quick. You'll see that I anticipated that trying to get this tissue over that volume might be a little difficult. So if you look at here, I included this circular incision up to this papilla, but not including it. I realized quick I was going to need a little bit of extra stretch there, so I extended it to include that papilla. And one thing I like doing for anyone that knows or has experience underscoring the periosteum, under the attached gingiva, yes, you are underscoring the periosteum. Up in here where you have your mucosal tissue, you're not underscoring periosteum. You're bisecting that mucosal tissue in the center. So some of it is staying, up against the bone. The other part of it is being separated, and now you can stretch it over a bigger volume. But if you just do it in this vertical direction, you're going to lose a lot of potential stretch that you could get if you release some of that mucosal tissue in this direction underneath the areas that you haven't even flapped yet. Okay, so often what I'll do is after I do all my scoring of the periosteum and my releasing incisions in that mucosal tissue, I will take the 15C blade and kind of go underneath here. So my flap isn't up here, but if I release some of that tissue in there, and you can only really do this in mucosal tissue down to about where the attached gingiva are firmly up against the bone, because then you're slicing periosteum and can come out the gums in a way you don't want to. But I do find that giving you a little bit of release in this direction here allows you to pull over this volume a little easier. Does that make sense how I'm explaining it?
Oh yeah, and I mean, one thing that a lot of people can do, or I've seen techniques where you can do this, is once you actually reflect a little bit more, you can actually take your suture and grab onto that tissue that's kind of laying on that bone still, and you can use that to hold down your membrane or whatever else you're gonna kind of use to stabilize your membrane or your PRF or whatever it may be.
Right. Now, are you a suture the membrane in place guy, or are you a tack guy, or are you a I can usually get it to stick in by itself guy?
Okay. I'm a tack guy. I'm a tack guy for sure. I'm a complete tack guy. But I've tried the suture with the membrane, suture the membrane down, and it actually got me great results. You just use chromic. Use chromic underneath and just to hold it down, because you just needed the chromic to stay for maybe 4 days, because after that, it's just everything is just naturally healing properly. And you've got that adhesion from the blood and the cells and everything. So yeah, it's worked as well, but I'm a tack guy. I'm just lazy. Yeah. It's just too much effort to go find a periosteum and grab some of that tissue and make sure that you don't mess with your bone. So I literally just tack my membrane down, pack my bone, and I put the membrane right over it, trim as I need to, tack it on the lingual, and I'm good to go.
Okay.
I move on my life.
Now, do you later retrieve the tacks, or do you leave them in if you don't have to touch them?
It depends. So I remember there's a patient that I actually did on the mandibular premolar area, and I didn't want to reflect all the way back again after I was placing the implant. So I left them there, and I explained to the patient, hey, these are they're titanium. They're going to be fine. You're not going to go through metal detectors, and no issues at all. But most of the time, I do try to get it back.
Okay.
I do try to get it back. But with this one, I remember that case because I tried putting it as coronal as possible, my tags, and it just was not staying. So the only place it would actually stay was as I went pretty apical with it, and I tacked it down apically, and it stayed. And I said, all right, let me just leave it alone now. It hasn't bothered her. I've seen her after for other treatment, and no issues at all. So if it's there, it's going to stay there, and there's no problems at all.
Gotcha. I'm actually, if tax is lazy, I'm even lazier, because I typically don't do any type of fixation of the membranes. What I have developed is a little way of, like in this case, for example, I might elevate this laterally or posteriorly, And then when I put my membranes in, I'll tuck them in the gums, you know.
You're using, which is actually excellent because you're using things around you to support it. It's
Right.
kind of like when you do the when you do socket preservation,
Right.
right? We can tuck in our membrane on the
Right.
buccal or lingual if you choose, So
Right.
you're doing exactly this. You just save yourself some money on tech. That's all it
Exactly.
is.
All right. So speaking of membranes, I almost always go with a resorbable collagen membrane. I've rarely ever used non-resorbable membranes. And the brand that I usually use is called Helimen, and it has a standard membrane that usually lasts about 8 weeks. And then there's the Helimen Advanced, which usually lasts about 16 to 18 weeks. So if I'm doing a larger graft, I'll use one that lasts a little longer. Interestingly, the same research that talks about the benefits of decortication also tends to address the need for occlusive membranes. Now, they're kind of taught as a staple. If you're going to do bone grafting, you have to have some to occlude out the soft tissue, cells from infiltrating, because they're going to travel way faster than the bone cells are going to travel to form new bone. But a lot of the research that's coming out there is showing that if you have a full thickness flap, your periosteum is really all you need to cover the bone and protect it from soft tissue infiltration. And that's something that I started coming across more and more in these last couple months, especially with the last Dental Town article that I was writing, that, it's weird that I'd never heard that before. And some of these articles are going back, I don't know, I think it was 2015, 2016. And I'm thinking to myself, I've been pretty knee deep in this stuff, and no one's ever come out to tell me, hey, you may not actually need membranes, especially if you have an intact periosteum. But then, the question bears, where does your periosteum begin and end in a large flap, right? And, are you, if you have a long tooth with a big buccal depression towards the apex of that tooth, is there going to be periosteum in that area that's going to protect that volume that you're adding?
I would actually be nervous because can we truly get flap that is immobile?
Right.
Because we know to basically immobilize that flap and make sure that it does not move at all, and to trust the patient's going to do the same for you is very difficult. And I think, to me, having that membrane that's almost like a separation is somewhat beneficial as well. Right. So if there's research is saying that the periosteum is what's actually going to help you out, and I can't argue that. I mean, I haven't done the research, but I think having a little bit of layer is beneficial. Like, for example, if I'd use a titanium reinforced membrane because I'm losing vertical, and I want to ask you, like, if you do that as well, or if you've noticed with vertical bone loss and you want to try to build up some vertical, if you use titanium reinforced, I actually still put resorbable membrane over it.
Right.
And I never thought twice because that's how I was taught, and it made sense to me.
Right.
So maybe I'm doing that wrong too.
Well, I don't think it's wrong or right. Whenever I see things like that, I always try to look at it in a layered, with a layered strategy. So, okay, technically you might not need a membrane in all your onlay grafts, right? So maybe that aspect of it is true. But we do know that we do need that bone to be stable and immobile. And can we trust tissues that we've released, that if you're doing an onlay graft, you score that periosteum. So that periosteum may not even be intact because you've been taking a 15C blade to it. And now that you've released that tissue and you've gotten tension-free closure, that tissue's moving. So what does that mean? What's happening to the bone underneath it? It's moving. And I like the fact that adding a collagen membrane, even if you aren't tacking it or suturing it in place, as it starts to, the blood in it starts to coagulate, you do have some actual physical structure that's giving it a greater ability to stay immobile than your overlying soft tissue is. And so, you know, aside from maybe if periosteum technically is enough, you know, just like we see in the sinus, right? You do a sinus lift. Under the Schneiderian membrane, there is a very, very thin layer of periosteum. You putting bone in there, you know, you don't always need to put some people use a 2-membrane technique where you put a internal membrane up against there. Usually that's more for the mechanical advantage of just tenting that membrane up as you're starting to pack material in there. But technically you don't need a collagen membrane in there, and it's a very predictable bone forming procedure, but also you're not worried about anything in the sinus really moving. You know, you have a membrane that's taut down all around that volume that you put in. So you have that tension around it that's holding it in place. And, you know, there's no lips, there's no muscle pull, there's none of that stuff that's going to affect your sinus because it's a protected area. But I thought it was interesting, and I was trying to figure out if that's something that the biologics companies are making sure we don't hear too much of because they want to keep selling membrane. But once I started thinking through it, I'm like, okay, there's a lot more to it than just technically, you know, periosteum can protect your bone graft.
Right.
So here you'll see I use a collagen membrane. I almost always use resorbable, and in larger onlay grafts, I'll use ones that either are cross-linked and have some longer longevity before the body degrades them down. I like to tuck my membranes underneath the flap that I've released, and I've tested its stretchability. And I will lay it in there and then see where I need to trim it. Because obviously once I lay it down up against the tissue, I don't want it sticking out through the seams. And so I'll place it in there, see where I need to trim it with some scissors, and then I'll lay it up against the bone, and I almost always cover it with a PRF membrane. Okay, that gives it some extra added stability, some extra added coagulation. You've got the extra growth factors that are coming from this concentration of platelets. You have the fibrin matrix that holds those growth factors in place longer than a natural clot does. And so the amount of soft tissue healing that you get when you cover it with a PRF membrane is amazing.
And to me, I feel like PRF is basically another layer of like membrane.
Yeah.
Right. Yeah. So you basically just double membraned it in my mind.
Yeah.
Right. There is that structural support too.
You can, and I'm midway through. Was it Joseph Marone's book? No, Richard Marone. Richard Marone's book, Understanding Platelet-Rich Plasma. And they've come out with an oven now where you draw your blood, you spin your tubes, and you remove that buffy coat layer that's rich in platelets. What's left, you bake it in an oven, and it denatures the proteins and hardens them, solidifies them. Then you remix your buffy coat layer that's got all the, you know, the platelets and the white blood cells. And now they're saying that denatured mesh of platelet and fibrin-rich portion of that blood is solid enough and stays solid long enough to be occlusive of any of the soft tissue cells, eliminating the need for membranes. And so I'm still reading on it, but this might be something in a year or two we're making a video about, because it seems like it's really cool stuff. And Richard Marone seems to be, you know, kind of the Elon Musk of platelet products. Yeah, I mean, if anyone doesn't have that book, I definitely recommend getting that book. It gives you a really good foundation on the history, the basic science, the utility of platelet products, but also the new innovations. But anyway, I use a lot of PRF in my surgeries, and I have seen tremendous results with my soft tissue healing, as we've talked about before. And then, as you can see, we got tension-free closure. So I'm able to close over this volume. You can kind of see where that volume is poking out, is sticking out. And you don't see any blanching or pulling of these tissues. I was able to release it underneath the flap, in the anterior direction and a little bit in the posterior direction. And so when I pull this down, I'm able to get really good solid closure over all of that volume. In this particular case with this patient, I told him I didn't feel comfortable making him a partial or a flipper, because he has he's been going all this time like that, so aesthetics is clearly not the biggest issue on his mind, but our restorative space was just enough. And when you have just enough restorative space for something like an implant crown, that means you probably don't have a comfortable enough room to put enough acrylic to be able to have a stable flipper and be gentle to the tissue underneath without every time him biting down on these worn teeth, pushing that flipper up into that surgical site.
So how did you know that you only had enough space for the implant restoration? What did you do before this?
Great question. So if I had known I was going to be presenting it in this way, I absolutely would have taken the photos that would have depicted him in maximum intercuspation. And then you measure the distance from the top of the gums to the opposing teeth, and in general for a back molar, if you have 8 to 9 millimeters, that's a good amount of height given, relative to the size of his other teeth. Some cases where the bite is collapsed, you might have less. And in those cases, what I have done where I don't have enough room, even if the planes are good and we haven't had too much collapse into the planes, but the occlusion has worn down and the teeth are short, if I have a lot of vertical height, sometimes right at the time of placing the implants, I would do some ridge reduction and create some vertical space, albeit I'll tell them that your gum line might be a little higher than it otherwise would be. But your only other choice is to do some full mouth reconstruction, build up all your other teeth with crowns, and you let them make that decision on how they want to proceed. Is it an aesthetic area? Are they an aesthetically conscious person, or are they a more functionally conscious person?
Could you have done like a wax up to also determine that, like a lab wax up to determine like what the teeth would look like, which would also go along the way, right, with occlusion and everything?
Yeah, absolutely. You could do a traditional wax up. In a lot of my cases now, with the advances that softwares have done, I'll do digital wax ups, where I can put the implant where I want on the on the CAT scan, and then I can tell the software to add a crown to it, and then I can see the dimensions of the crown, and I can see where it occludes and how much space I have, and I can actually measure it. So yeah, you can definitely do a wax up. You can do a digital wax up. Once you've been doing this a while, a lot of times you can just take a look, have them bite down, and in your eye, you're like, all right, you're good. But if this was to, now that I'm back in school, if this was a school case, first thing you do is you get a diagnostic wax up, right? And I absolutely see the utility in that. And there's still a lot of cases where I will do a traditional wax up just so I can look at it physically from different directions. I can look from the back of the model. I can do my excursives, and especially if we're doing anterior work. I'm not as technology savvy, nor do I have the software to really have interactive digital wax ups, especially for anterior work where you're looking at, excursive patterns and protrusive patterns and so forth.
And one thing that you were kind of lucky with is he had a posterior stop.
Yeah.
So you were able to kind of know exactly what his, where the occlusion would stop, right? You didn't have to create any kind of vertical or any, guess on the vertical aspect of it, because this, that last tooth factor basically allowed it to stop exactly where you want him to be and how he normally functions.
Right. And looking back, one thing that helps, and if I can go back a few slides, is that he does have stable occlusion on the other side. Now, you and I have seen, if they're missing posterior teeth on both sides, often you'll see the gums are right up against those lower teeth. And at that point, you're really looking at, all right, do we want to take everything out and do a full prosthesis? Because we have to really reconstruct this bite, and we have nothing on the posterior to do that with. If we try to do implants and build up your bite in the posterior, then we would have to do all new crowns on the anterior. So there's really no easy way to do it.
And I mean, I think what I'm getting at is, in the end, the best thing to do is to plan ahead.
Right.
Right? Planning ahead allows you to know so that there's no surprises. And I think that's something that we always have to tell everybody is if you plan ahead, there should be no surprises at all for the surgeon or the restoring doctor. And that's something I want everybody to kind of get into.
No, absolutely. You know, making sure that you're doing restorative driven implant surgeries is paramount. I've seen cases come to me where the patient had an implant placed and they say, you know, hey doc, you know, it's been 3 months, you know, I had this placed in a different state, I'm ready to get a crown. And, you know, it's in an area, you know, let's say it's, you know, number 18 or number 19 where the implant is, but because the tooth has been missing so long, the opposing tooth is over erupted and there's only 2 or 3 millimeters of space, you know, and clearly whoever was looking at it, they saw the bone, the edentulous site, but they didn't look at the big picture and they didn't plan ahead. They didn't say, okay, I want to put a crown here. Let's start from there and reverse engineer back to this implant, you know, because, oh, hey, guess what? I don't have room for a crown there. What other steps do I have to do first? Do we intrude that tooth? Do we, you know, root canal and crown and shorten it? Or, you know, there's often options, but if you don't look at them, now I'm the one that's got to break it to the patient that, hey, I can't put a crown on your implant, you know. So if you can avoid that by planning ahead, that is going to save you a ton of headaches down the road.
Yeah, that's genius.
All right, so we got closure. Patient comes back. This is probably 5 months later or so. The larger the graft, the longer I wait. So I'm assuming this is about 5 to 6 months later. You can see we've got some really nice tissue that has healed there. We didn't get much recession or attachment loss at all in this area. You know, our frenum isn't attaching super low because our implants are going to be down in this area of attached gingiva. This is our occlusal view. You can see some really nice width that we got there. Now, this can be deceptive, right? It looks wide. On the CAT scan, this is the before. So some of our dimensions here, where their canine was, we had almost 8 millimeters. And again, we just wanted to preserve that. Where tooth number 5 was, we only had about 6 millimeters. Back where number 4 is, we barely had over 6 millimeters. In the area of number 3, I felt like we were okay. So we were primarily concerned with this premolar area. And this is our after. We were able to maintain our dimension in that canine area. So it's about the same, about 7.9 millimeters. So that's a win. All right, that's a W I'll gladly take. We went from 6 millimeters or just under 6 as we had initially looked at it, you know, to almost 10 millimeters of width in the area of number 5. And then the same thing, we went from 6 to about, you know, just over 10 millimeters in the area of number 4. Now, again, this can be deceptive. So at every layer, I always like to double check my work because I've had cases where I've done a graft, everything looks like it healed well, there was no infection. Patient comes back, the ridge looks nice and wide. I go to start my implant, the CAT scan looks good, looks like I got a ton of radiopaque mass in that area. I go to put the implant in there and I get all these granules starting to come out. And then you start crying because you don't know how much is that. All right, is there just a little bit of retained bone graft, but there's still some healthy, you know, new de novo bone in there that I can rely on? And in a handful of cases, I've had to tell the patient, hey, I did everything according to textbook, but if we didn't get the results we want, I want another opportunity to open it back up. I'm gonna clean out the stuff that was left behind that didn't convert, and we're gonna try this again. Okay, so I always like to double check my work, especially in larger grafts. Last thing you want to do is be in a state of denial, put some implants in bone that probably shouldn't have implants because it's not true, you know, it's not de novo bone that's vital, and then you go to restore it and the implants just start twisting out. Okay,
And another thing I was just about to say, you actually just brought it up right here. You also want to make sure that the height that you got was all the way as high as you could, right?
Right.
Because you could get it on the crestal part, maybe all the way for like 5 millimeters, but then after 5 millimeters, you don't have that thickness.
Right.
So you may be puncturing out of that buckle, right? If you put a 8 millimeter, 10 millimeter, 12 millimeter, 13 millimeter implant, you know, so that's something you had to make sure. But yeah, you're probably going to see that. So I apologize.
Which that is a great point. I actually wasn't thinking about including that point, but I'm glad you brought that up, because when you saw me in the beginning and you saw how tall I made that flap, how vertically I created that flap, it was specifically because this depression was as large as it was. If we had nice wide bone and only a small area that I wanted to augment, I may not have laid that flap as high. But knowing that I'm trying to create volume in all of this area, you know, upwards of 10 plus millimeters against that cortical plate, you have to be able to expose it to then be able to add the volume of bone, to decorticate it, to stretch the, you know, the tissue over it. That is a great point. You always have to look at vertically, not only how wide you want to get horizontally, but what your width is, how deficient is your width in the vertical dimension as you go up. Because you want to be able to put an implant in and have the apex just as securely in bone as the neck, okay? So here, you'll see we've got, let me see if I can move our window here. We went from having 5.8 millimeters of bone, and now I'm able, I didn't measure this here, but I superimposed the implant. I believe this is a 4.1 millimeter implant. And so we've got bone all in this area that was deficient up to, you know, this height here. We've added volume. So now we can put a 10 millimeter implant in there and have it securely in bone in all dimensions. So that's one of the other areas here. This is us planning our surgical guide on Blue Sky Bio. So everywhere that we looked that we wanted bone, we got a tremendous amount of bone. So we're going to do 4 implants for 6, 5, 4, and tooth number 3. This one here, we went with the shorter implant, an 8 millimeter implant, just to bump up against that sinus. And instead of really doing any true sinus bump or even using the VersaBurrs, all I do is I drill right up to the sinus floor. And then when I put my implant in, I just put a little bit of vertical pressure and it just pops in there. Okay, and you can do that without fear, but you got to have a controlled hand. The last thing you want to do is put a whole bunch of elbow grease in there. Now your elbow's deep in the sinus. Okay. But in a case like this, where we're doing multiple implants next to each other, even with my experience, I still prefer guided. I want to make sure that I space everything in a way that makes it restoratively sensible. Right? Meaning my distances between the implants and the adjacent teeth are well within the limits that allow me to put restorations that are not only harmonious, but that are not impinging on the tissues in a way that's unnatural that can give us problems down the road. And, you know, buccal palatally, I want to make sure I'm in the center. Okay, I want to make sure that I'm engaging some of that native bone. Because as we've known, when you do any type of graft, you may be getting 30 to 45% de novo bone, but a lot of that is remnant bone graft material that's now been incorporated in that mix and mesh of your own new bone. So if I can engage maybe 70% of this implant surface in native bone, that's 100% bone, right? And even though, you know, and it's like in the case of sinus lifts, we know that even if you were in that 30, 35%, you know, live vital bone, it's still enough to support an implant. I like the thought of being as much as possible in the healthiest, most vital, most highest percentage bone area as possible. And using a guide, I can make sure not only am I in restorative harmony with my planned restoration at the end, but that I'm also maximizing my position within the native bone as much as possible.
And a lot of people don't remember this, or at least don't think of this, but bone continues to resorb, right? As we age and we get through this. So maybe in 5 years, what you have here, you may have 10 millimeters now, but in 5 years, you might have 9. We don't know.
Yeah.
We don't know. Anytime you do surgery, you basically get rid of some of the some of the blood that actually supports and kind of heals and feeds the bone. So resorption does happen. No matter, anytime you go in and do surgery, resorption does happen. So that's something to think about.
And not only
great, I mean, how thick you have on the buckle.
Yeah, and not only does it happen, it can hurt your feelings when it happens. Because I've had it where, I'll do follow-up sectional CTs on some of my patients 5 or 6 years later, and we went from having 3 millimeters on the buckle of an anterior, now it's 5 years later, and it's barely 1.5 millimeters. And you look at it, and you're like, ugh, but it looks good. It's still healthy. The soft tissue looks great. That is absolutely to be expected. In some of your patients, that bone's going to stay a great amount, especially if you had a really thick buccal plate to begin with, so you had a really strong medullary portion. If you've grafted a lot of that, it's almost always going to resorb down to what the body finds its harmonious balance is with the neighboring contours, the existing potential blood supply, and so forth.
And a quick little thing that and this too, the thicker your biotype or your tissue is, the less resorption they've noticed happens over time. So thick tissue. So let's just say that your tissue on the buccal side is thin. There's nothing wrong with basically doing a tissue graft to thicken that up, which would then help you in the long term too. So a lot of people have started doing immediate implants with what's it called, tissue grafts.
Right.
There's nothing wrong with that as well. So
there's nothing wrong with that at all. And I've always, as my skill has grown over the years, and I've become comfortable, especially with doing a wedge technique to get some connective tissue from the palate, and how easy it's become for me now. It almost hurts not to do it. You almost don't even want to give them the option. You almost want to tell them, listen, I will do this only if you let me do this. Now, there's an extra cost, but I won't do this if you don't let me also do this. And you have to find a balance between, what your version of the absolute ideal is, and is that absolutely necessary for a successful result for every single person? And then do you impose that on them? And that's just, your whatever practice philosophy you have. And my philosophy tends to go back and forth sometimes depending on my mood, time of year, recent experiences. But I would love if every anterior implant and or immediate implant, I could just normalize a connective tissue graft, because why not?
I mean, we have to be realistic. Cost does play a factor, but you're right. Ideally, that's what we want to do.
Yeah.
That's what we do, and that's what we I think that's what we should do. But there's a lot of other factors too. But yeah, that's just, a little tidbit just for whoever's listening to think about that, right? If you want to try to minimize resorption over time, make sure that you also have very thick tissue in that area. Thick tissue helps with a lot, right? Yeah. Not only does it help with occlusion and contour and aesthetics, but it also helps with the underlying bone as well. So
absolutely. So let's see here. So here's our guide. Like I said, me and my partner, we usually plan them on Blue Sky Bio. Blue Sky Bio is a great company because a lot of that software is free. For some of the advanced features, you have to buy a subscription. But for just treatment planning, it's a great free software. I typically use Anatomage, but we've, as part of our business, have bought the licenses to it to get some of the added features that it has. But if you're a doctor that's just getting started and you want a really good software that's has a lot more bells and whistles than the other software's basic viewing software, then Blue Sky Bio is a great one because it's free, and free is always good for dentists.
Yes.
Oh, go ahead.
No. I listen, I love free. I love free. So anytime you say free, I'm writing that down. Blue
Right.
Sky Bio. Remember that.
So here is our implants in place. If I remember correctly, or just off looking at these, I want to say this is probably a 3.7. These are probably 4.3 in diameter, and I want to say this is a 5.5 by 8, and these are all 10 millimeter lengths.
So does Blue Sky Bio have different implant systems in there that you can kind of mimic the sizes, right? Because we all know not every implant system has the same size. You know, you might have a 4.7 for one company, but then maybe 4.3 for another.
You know, it does. It has its own catalog of different implant systems. And then if yours isn't in there, often a lot of the companies, they're copies of other ones. Like the dentist implants are copies of Dentium.
Mm-hmm.
And so if you use the Dentium library, it's the same exact dimensions. But then it also has a feature where you can custom put in your dimensions. You can tell it if it's a tapered implant, what the neck size is, what the apex size is, and it'll give you that image, so you can get a pretty accurate superimposition of that implant in your software when you're planning. So you can see I pushed that one right up against that sinus floor right there. But you know, with this guide, I was able to make sure that all my distances were, you know, pretty even and harmonious. Had I freehanded this, even if I used little spacers, you know, there would be a lot more irregularities, especially when I'm doing 4 implants. If I'm doing 2 implants in the posterior, I probably won't use a guide. But if I'm doing these many implants right next to each other, then I do need the help of technology to get it as near to perfect as possible. Now, like I said, because the CAT scan can be deceptive, what I like to do in some of these cases before I put the implant is, I like to, even if I'm using a guide, I still lay a small flap. So the angle here is a little deceptive. So this is just the crestal bone here, and I'll extend it over the buccal plate just a little bit, just so I can see what quality that bone is. And I'll take a periodontal probe and I'll poke on it, because I want to see that it's solid, that my probe isn't going to sink in on it, right? I want to see that it's not chock full of granules that are not only loose on here, but you'll see them loose up against the periosteum if it's not a well-developed site, and you have a lot of you know, bone that hasn't formed. And then what I like to look for is bleeding. Am I getting that same type of bleeding that I would from a natural cortical plate, where it's not pouring out blood, but it's just kind of slowly oozing blood over time? And I can take a piece of gauze and I can dry it, and it'll be white, and then you'll see some red just slowly ooze out of that surface. That's how I know I got good solid bone, because I physically tested it. There's no loose granules, and I see an active blood supply from releasing that flap. Okay, now don't release it a lot. I release it just enough, just to see, you know, 2 at most, maybe 3 millimeters of that volume that I tried to add on the buccal there. Okay.
So here's a question: would given more time equal bone formation? Does that make sense? Right. So if, like, okay, you had granules, would given another month or 2, would you all of a sudden form bone? Because I'm sure somebody's asking that question.
Right. Typically, if it hasn't happened in the first 5 months, it's not going to happen.
That's right.
And that's the same thing goes with implants. I've had 2 implants over the years sent to me from, you know, local doctors that you know, either have taken my course or, you know, have assistants that have worked for me before, and say, hey, whatever we got going on, why don't you send it to Dr. Horton, take a look at it? And it's the same scenario in both these cases, where it was 3 or 4 months later, they went to take off the healing cap, and the patient winced, right? And the doctor told them, oh, maybe it's not fully integrated yet. Maybe we should wait a little longer. They waited 3 or 4 months, came back, went to take off the healing cap. The patient winced. On the x-ray, it looks fine, right? There's no lesion, nothing. You see bone right up to the implant, but clearly you're not. maybe there's a little discomfort from the
Soft
connective
tissue
tissue
pain.
attachments from the gingiva to the healing cap, but that's rarely enough to make a patient jump out the chair, right? And so, I had to break to the patient, like, look, if the integration doesn't happen in the first 3 months, waiting isn't going to make it happen. The only thing you can do is take this implant out and put a new one in. It's the same thing when you do a bone graft. If within the first 5 months you go in there and nothing's taken, you've got to scrap it, get rid of that old material, and start over. But that's a great question, because it does beg the curiosity of, oh, well, you said after 5 months you're at 30 to 45%. Well, if you wait longer, it's more, right? Typically, that's whatever is going to happen is going to happen in that first 4 to 5 months. Favorably anyway. Over time, like you said, you do get some remodeling and shrinkage. But here with my, we use the guide to create our osteotomies. Our implants go in. Now, patient came back after about 3 to 4 months. And in this case, where I have a bunch of implants right next to each other, instead of trying to do tissue punches over each individual one, I just make a small incision from here all the way back across the center. I can kind of feel where those implants are with my 15C blade. I just lay a small, tiny flap, just enough to be able to see the top of the cover screws. I remove the cover screws, put healing caps, bring the patient back 3 weeks later, and take my impressions. Now, I don't have, and I could probably go back and get pictures of this if I ever have to present this case again. I did the impressions digitally on this case. And what you run into with digital impressions is the impression copings, they all look the same. So when you have a number of impression copings all next to each other, the camera gets confused. And after you've scanned your first one and you start scanning your second one, you move on to your third one, the image starts jumping because it's starting to recognize that third one as your first one. So then it shifts and starts painting over your initial image with your posterior anatomy, and it becomes very difficult. So if you're doing multiple implants, my recommendation is either do standard impressions, or if you're patient enough, what you do is you put the first impression coping in, scan that all the way. You can actually lock it in your digital impression, so that way the camera isn't looking for that anymore. Then move on to your second one, then lock that, then move on to your third one. But that's something, if you haven't done it by trial and error, you haven't picked up that tip. So if you're having multiple implants next to each other and you're just getting into digital impression taken, and you see that it's jumping from one area to another, it's because it can't tell the difference between your third impression coping and your first impression coping. Make your life easy and just use traditional impression copings and take a PBS impression. Okay.
And I want to mention the fact that when you make that crestal incision, you moved some of that keratinized gingiva. That's what you need on the buccal and lingual. So you move that keratinized gingiva to the buccal. And that's what helps with occlusion and, again, not having pain when the patient goes to chew, right? You're not traumatizing that soft tissue. So I can see that you have at least 3 or 4 millimeters of keratinized gingiva.
Yeah, and luckily with this guy, he had some, medium to thick biotype, and then pushing that extra tissue forward gave us a really, really thick band of keratinized tissue, which, especially when you're looking at multiple implants and hoping to maintain some semblance of papilla, having good thick tissue there is always going to help. Here you see we've placed the restorations. These are all screw retained restorations. You can see the screw holes here, and I can't make out the screw hole here. I think it's somewhere there, but obviously we place the implants in a way that we're able to build very harmonious anatomy and contours into our final restorations. This is our initial seating here. I would love to see how this tissue looks, because as you know, anytime you're doing multiple or even single crowns, you take an impression, the lab makes you the crown. Often when you're tightening it down, it might be impinging on that tissue a little bit. You might have to adjust it, or you might just, push it down and wait for the gingiva to adjust and remodel a little bit. But one of the hard things to do is to recreate posterior papilla in an area that's been edentulous for a really long time. And so that's something I spoke with him beforehand, and I said, this natural scalloping, I'm not to the point where I can, had a lot of experience scalloping the bone and then kind of recreating scalloping in the soft tissue. And I've seen some of that done. That's not in my tool set yet. And so I always let the patient know that I may not be able to recreate this natural scalloping that you have on the other side 100%. But in general, you're going to have nice, healthy gingiva. You're going to have nice contours on your final restorations. It's going to feel good. It's going to look good. And no one's going to be looking at your mouth like this but me. Okay, and I know what's going on. So here's another photo again. We've got, some papilla that we've been able to maintain there. Here, for the most part, is going to be a little flat, and I'm okay with that because he does have a thick, a thick biotype. We've added some extra tissue there when we push that keratinized tissue to the buccal. And over the next few months after that, and this is probably I probably finished this case about 5 months ago. So I would love to see a follow-up to see how everything looks now. And next time we talk, if I've gotten one, I'll share it with everybody. But everything is nice and thick with some good occlusion here that you can see. It's a shim stock occlusion that's point occlusion. So there's no excursive contacts whatsoever. You can actually see that I don't have these buccal cusps hanging too far beyond the lower teeth. So that way, when he grinds and he protrudes, the only contacts these teeth have is just in maximum centric occlusion, and there are point contacts in the center. Okay, and that's something you do intentionally, especially on someone that's a Bruxer grinder like he is, and then you're just adamant that they get a night guard. And what I always tell the patients in my warranty forms is that if they don't get a night guard from us and there isn't sufficient evidence that they're actually using it, then I won't honor or guarantee the implants. I've never really had to do it because I don't get a ton of failures, but it's nice to give yourself that out. If someone does come back and they've just demolished their teeth and demolished their crowns and implants have failed, or you get bone loss and it's clearly because of bruxism and they didn't get that night guard that you recommended, then you want to at least be able to say, hey, I told you I can readdress it, but I can't do it for free.
So after you put these crowns on, when does the patient come back for maybe occlusal adjustment or just evaluation?
Usually I like to see them usually within a week or two for a quick follow-up, especially when I've done these many implant crowns, right? If it's just one implant crown, I'll just say I'll see you at your next checkup or your next cleaning. When I do the larger cases, I like to see them in about 2 weeks, because what I found is that I'll bring them back in 2 weeks, I'll check occlusion, and there's almost always a high spot we didn't even see last time. Mm-hmm.
Yeah, that's it. And I don't think a lot of people do that.
Right.
You get excited that the crowns are in, and then they're like, all right, see ya,
Right.
And it's funny. I always tell all my restorative doctors, I'm like, there's nothing wrong with bringing them back multiple times within that first year to check occlusion, to check to make sure that there's no issue, check to make sure that they know how to keep that area clean.
Right.
Have the hygienist educate them. All these factors are so critical to success long-term of your implant, right? Occlusion is, I know if you go to a pros conference or talk to a restorative doctor, it's never the occlusion. It's always the surgeon. You know what I mean? And I love my restorative people, but it's always the restorative that, the surgeon that messed up somewhere.
Right.
And I always tell them, like, just check occlusion. I bet you have a high spot somewhere that could traumatize that implant or that soft tissue, whatever it may be. So I always just say, Check occlusion consistently for the first year. Make sure everything looks good. They know how to take care of it.
Yeah. You know, and it's not only occlusion. What I found is that there may be times where an interproximal contact, although present, isn't very functional. And they'll come back and they'll just think, oh, well, maybe that's just part of having implants, right? And they got a food trap. And you want to be able to mitigate that, because that can be a potential source of inflammation and some, peri-implant mucositis that can lead to peri-implantitis. And it's nice to be able to see them after they've used it with regular food day in, day out for a few weeks. And you ask them, how's your flossing going? You're flossing, right? And of course, they're going to say, yeah. Are you trapping any food? Now, I'll go in there and I'll floss just to make sure I'm not coming out with any shreds of beef or, green leaves or anything like that. Because there may be times you have to adjust the contours interproximally, because you can have a interproximal contact that's like this, but and when you put the floss in, it snaps, but the contact is way to the buccal or way to the palatal, and you got a big food trap in the rest of it, right? Or you can have a interproximal contact that way, but what you want is a harmonious one that's centered, that really does a good job of keeping food out. And so that's the other thing that I found, aside from double checking occlusion, is really double checking what the hygiene in that area looks like 2 weeks out, to make sure you're not predisposing them to, some potential cause of inflammation.
That's it. That's it. I can't say anything more.
So that's another occlusal view. This is our post-op photo. Sometimes, like I said, I'll take some CTs afterwards to double check my work. So here you can see, again, very good placement of the implants. This was before I restored them, obviously, because I wanted to make sure that where I planned my implants is where they ended up. Okay, sometimes guides and technology can be off, but you can see in all areas, I tried to keep the bone or the implants coming out of the bone in a way that was harmonious with the eventual restoration, and in a way that really maximized the native bone that we had.
And with that number 3 area, that molar, you're not that close to the sinus compared to if you look at it on the pano.
Yeah, and the only thing I can discern from that is maybe this slice is in this mesial portion. And if I moved it back maybe like 1.5 millimeters, I'd be closer to that sinus, But overall, I mean, I think this was a very good case. He clearly has some, other work that needs to be addressed. But, you got a happy patient, and you got a patient that's trusting enough to come back. And a lot of times when you have the train of thought where they say, all right, well, you got to finish everything else first, then we'll do the implants. I think if you have enough trust and rapport with your patient, they've been with you long enough to where you know that they are going to be regular attendees to at least their checkups and their exams, and they do get some work done as you've recommended it. What I don't want him to do is never come back to the dentist again. So there are some cases where if they've got a lot of other work to be done, I'll tell them, if I don't know them or I don't trust them because of their history, I'll say, get everything else done first, then we'll do that. With him, he needed SRPs. He came back, got all his SRPs done, came back for the 6-week evaluation, came back for 1 perio maintenance, which that was my minimum I told him he needed to do before I would do the implants on him. And I think there was 1 or 2 things that we ended up doing restoratively. I think we crowned this tooth initially, and then at that point I said, all right, we can go ahead and tackle this area because it's high on your priority list, but then we got to take care of this lower right sooner than later, and I think that was it, my man.
Awesome. Again, wisdom, man. Again, wisdom. I truly believe that, cases like this just show just a whole gambit of skills that you need when you're doing implants. It's not just a matter of, oh, I have a hole, let me just place an implant in there. There's a lot of pre-planning that a lot of people don't talk about, right? When they go to a conference, they talk about the success and look how great this looks and look at that. But there are some times where we fail because we didn't plan ahead.
Right.
You know what I mean? And that's something that I think we need to talk more about. And that's something that we need to get people to understand, that planning ahead really does save you a lot of headaches later on, you know? And so again, you know, you see these kinds of results and you're like, this is great. But we also have to talk about all the steps that you took to before you could even, lay that flat.
Right.
I'm going to keep mentioning that and keep talking about that. I don't care. As a periodontist, I know I'm supposed to do this, but I don't care if you do implants. You know, I don't care if a general dentist does implants. I was a general dentist and I placed implants. I don't care. I do care about is let's not like, you know, degrade and belittle the process and the skill set that it takes. All because you want to take one course and then all of a sudden you want to call yourself an implantologist, whatever new term is out there. All I'm saying is let's plan ahead, people. Let's talk about this. Let's do it right. Hell, you know, send me an email. Show me your case. I don't care. Let's have a discussion. I'll volunteer to have a discussion, right, so that you at least think through your implant case. You're not competing with me. I don't care. You're not competing with you, doc. Like, you know, it's just a matter of let's do what's best for our patients. That's it. Right. Get off this floor.
I tell you what, man, it's been fun. I know that I've seen you kind of slyly, you know, hide your yawns there. I know you're 2 hours ahead.
Oh, bro, you know I'm tired. You know what? It's been a long day. You know, it's been a long day. When it came to, you know, the little one wasn't feeling well last night, so she got up at like 4 o'clock. So I've been up like since 4. You know what I mean? And of course, I stay up at the time where she's taking a nap. I'm usually, okay, let me get in a little bit of nap, and I stayed up to watch soccer. So I thank you. I definitely do. I thank you so much for coming on, man. Appreciate you so much for just taking the time, because I know you're in residency right now and you're doing it, and you're probably reading way more, you know, articles than any of us read in a day. You know, I remember those days. You know, so definitely appreciate you so much for doing this. And if at any time you want to come back on, even just to come and hang out with us, man, please come on.
Yeah, we'll do it soon, man. Well, I'll text you over the next week or two, let you know how things are going, and we'll plan our next session. Hopefully, Kyle comes back from becoming a Navy SEAL, and
let's hope that he wants to still do dentistry. Right. We're into a Navy SEAL person, but I hope that he's gonna listen to this and he's gonna know that we had jokes for him. But you know, actually, we got some great stuff coming up. You know, we're actually gonna talk to a dental student that just graduated. Well, a doctor just graduated from dental school. So we're going to get to know how that last year with COVID, you know, 100% COVID was. We're going to talk to, and I'm very excited about this, this doctor who basically, he treats his patients, and this is a DO or MD. Yeah. That treats his patient holistically. So he's going to talk about CBDs, and he's going to talk about just using natural, treatments for just your overall body and the overall health, mind, body, and, you know, spirit. And so it's coming up. I'm very excited about that, because, you know, for us, you know, we always think dentistry just stops right here, but it's your whole body, right? And dentists, we are so notorious for having bad backs, for having poor diet, for, you know, not exercising, except for Kyle, who wants to be a Navy SEAL. You know what I mean? But I'm telling you, man, this guy is incredible. He kills it, you know. So he's going to come on. He's going to educate us. And, you know, if you want to join us on the conversation, by all means, please do, you know. Yeah. But this is coming up soon, and we have a lot going on. So it should be fun, man. We have a residency director that we're trying to get on so he can talk about general practice residencies, what to look for if you're applying, and all the factors that go into that, and what makes a residency a good option for people. You know, not for everybody, but for a lot of people, I think residency, especially now that schools are definitely diminishing your requirements. I think another year, if you don't get the opportunity to be mentored, another year of education is key. So well, we have a lot on the plate here, man, but definitely you are official, unofficial co-host. So, you know,
I appreciate that, man. Appreciate
you know what I mean? So go enjoy yourself. Go relax. I'm going to go to bed.
Yes,
but we'll talk soon, brother. I appreciate you, man.
All right. Take care, buddy.
All right, bro. Later.